All right, I'm going to start off. Dr. Dietz, what is ischemia?
What is ischemia?
There's a microphone here in front of you.
Oh. So I think your question's regarding the rare bowel ischemia that I mentioned, secondary to the fibrosis process from the serotonin. Ischemia is decreased blood flow. To make it simple, sorry that I used that term and didn't explain it. It's extremely rare. We rarely see clinical manifestations of ischemia, bowel ischemia in the setting of carcinoid. You do see fibrosis of the vasculature, but it's typically venous. It's not arterial, so it doesn't really cause a lot of problems for patients or symptoms. It's extremely rare. The ischemia with the carcinoid is from just thickening of the inside of the blood vessel, just like we would see inside the heart valves and you know, the adhesions that I talked about in the bowel. It's the same process, but it is venous, not arterial, so it typically doesn't cause a lot of problems.
Dr. Warner wants to chime in on that.
I have to take a slight different view of the occurrence of ischemia in the bowel in carcinoid. I don't find it to be that rare. I think the surgeon, Dr. Liu, may agree with me that sometimes when there's intestinal obstruction due to carcinoid, the same process will interfere with the blood flow to the arterial arcades or the venous blood coming from the intestine and impairs adequate blood flow and oxygenation, and hence ischemia threatens to make decay or perforation in the intestine, and we have to consider that also as a risk.
Actually, maybe I can clarify just a little bit. So it's a little bit of both, obviously. So the true ischemia is when you have a true blockage and a decreased flow of blood to the whatever organ is, and actually that is relatively uncommon. What happens is it's a little bit confusing, and there's some subtleties to it, but there are two types of metastases to the mesentery. One is a classic lymph node metastasis, and one is actually a venous tumor deposit, okay? And so tumor deposits in general tend to clot off the vein that drain the bowels. And so, you know, when Dr. Wang operates, it's not uncommon for us to see the veins kind of all clogged up, and you get kind of swelling and congestion in the bowels. And that actually is kind of the bigger issue that's the more common issue. I mean, the true kind of what we call intestinal angina is still relatively uncommon, I believe, in my practice.
I have to say something about this. Maybe I'm looking at a more different spectrum of the disease. Most of the time, patient get to me already went to 3 different hospitals, and the surgeon already declared unresectable, and I come out and me. I don't know if you remember when I showed you all the picture, I opened up. All those patients had the venous congestion or arterial insufficiency, depending on which way you look at it. And one of the reasons I keep promoting all surgeons need to take aggressive gesture to dissect out all the tumors around the vessel, because I think that the long-term consequences, you don't take those, one of those tumors keep growing, eventually will block the blood supply, and you can have also, all of a sudden you have intestinal infarction, your intestine die from lack of blood supply, and sometimes you acute perforation. And we see those kind of patients occasionally when they come to the emergency room without any warning, and we had to operate on them, find the bowel was perforated, and we go in there, the bowel looks ischemia or dead. So in a preventative gesture, I do recommend people really go for that. And as a matter of fact, one of the things I strongly oppose surgeons to do this kind of surgery with a laparoscopy is because they can never examine the nodal basin of the disease, which potentially can occlude the vessel down the road. And they put a scope in there and say, aha, I see the tumor here, I take it out without making a big incision. They never put their hand into the abdomen like Dr. Warner suggests. The surgeon really need to check out every inch of intestine to feel inch by inch to make sure you don't miss a small tumor. And like the birth stuff I showed you earlier, most of the tumor is so small and they can be easily missed. Without putting a hand there, put a scope in there, can easily miss. And those lymph node ready to attack the vessel, ready to occlude the blood vessel, will never be detected by the laparoscopy. I just look at our group of patients we have to reoperate on. And most of the patients we ended up having to reoperate on after other surgeons did the surgery already, came to us because the surgery was done with laparoscopy. So I'll be very, very, very careful about it. A lot of people say, oh, I don't want a big incision, I want to recover faster, I want people to do the keyhole surgery, put a camera in there, do my surgery. Be careful about that.
So let me, I have to disagree just slightly with that. So I do them laparoscopically, and the reason is because you can make a smaller incision, but what you have to do, see, these are fine, subtle points, and this is why it's really important to see someone who does this a lot, is what you can do technically is you can exteriorize all of the small intestine when you can, and then you can palpate everything still through a relatively small incision. So there are technical aspects to it. The problem is actually Dr. Wayne's 100% right. If you do it with someone who doesn't know what they're doing and doesn't exactly kind of do the right technique, then it is a problem. And I've had to do the same thing. People have less stuff inside there because they had some small incomplete operation and then you have to go clean it up. But still, laparoscopy is still a very powerful tool in the right hands.
I kind of have to disagree with you. Ladies and gentlemen, we're in a civil war here.
That's why I put Dr. Dietz between you.
In the early stage disease, I think it terrorizes the intestine, you can palpate it. But the lymph node at the root of mesentery is the most common. The tumor at the root of mesentery usually go behind the pancreas, around duodenum. You can never feel it.
But you know that. Usually you know that.
No, not always. Not always.
All right, I'm going to move on to the next question because we'll be here all day otherwise. And this, unfortunately, this one I know can be controversial also. If you do not have a diagnosis for gut carcinoid, is sandostatin still recommended, and what benefit is there?
That's your question, Dr. Warner.
If I understand, you're asking me if you don't have a diagnosis of carcinoid, is sandostatin recommended? Well, when you say if you don't have a diagnosis, I presume that means you have symptoms that suggest that that's what you may have, like flushing and diarrhea. Are you the questioner? Yeah. Let's have you repeat with more details what you're asking.
I do have carcinoids, but not gut carcinoids. I have them in the brain, I have them in the lung, I have them in the liver. Is sandostatin beneficial?
I understand. For those who didn't hear, the question is, if you have carcinoid, but it's not from the intestine, but rather somewhere else, as in the lung and metastatic, and you have the symptoms, or even without symptoms, is sandostatin still useful? The answer is unqualified yes. It has not only a benefit for controlling symptoms, but it also is helpful, as we have now learned, for having some beneficial effect in inhibiting tumor growth. And a recent study called the Clarinet study, which is for lanreotide, and not yet approved in this country, but a similar somatostatin analog, used though in widespread use in Europe, has found the same thing, but not only just for carcinoids, but also for neuroendocrine tumors.
All right, Judy gets a little privilege because she does a lot of work here.
No, I just want to ask, because people have asked me, does it matter if it's typical or atypical?
Does it matter if it's typical or atypical?
No, it'll work in both instances. It's not that good though in the extremely aggressive, the so-called grade 3 or small cell carcinomas, the very, very aggressive neuroendocrine tumors that are really not exactly full-scale neuroendocrine tumors.
Okay, one that I can almost answer. Can we view this conference again? Is it available online? Not yet, maybe even in the future. Check carcinoid.org and keep checking, because they're the ones who did the video, the Carcinoid Cancer Foundation, and if it's going to be available, they should be able to put it up there. Dr. Warner, go ahead.
I can answer that off the record. It'll take a few months to get it edited and fixed up, but it will eventually be online and available.
Okay, a statement, cancer loves sugar. How much sugar is acceptable in your diet? How many grams? And if you disagree with the statement, let me know. How much? Cancer loves sugar. How many grams of sugar is acceptable in your diet?
Well, since I had a donut this morning, I don't think I'm really the one to answer that question. I don't think there's a fixed value. I think in general, you know, sugar. I think sugar is, in general, kind of a not healthful kind of thing. So less is more, I think. Less is more, and that should apply to everyone. You know, this is what. Let me tell you what I tell my patients, and you guys can tell me what you think. But I always tell them that the most important thing is to eat a balanced diet, to have a lot of color in your food, right? And these are very basic things. To completely avoid sugar is almost impossible nowadays. And so what it is just keep everything in moderation, and to, you know, as you know, if you need protein, then protein is what you need. If you need, you know, fat for whatever, that's what you need. So, and you should always consult a nutritionist because they can help you with these things. But it, you know, I think completely cutting out sugar is still not a bad idea. It's just it's hard to do.
I was a second guess that the question, whoever asked the question, I think you must heard we talk about the PET scan because the tumor uses more glucose, that's why it light up. So you see much glucose must be bad. The glucose is one of the things your liver will produce. It's called gluconeogenesis. So whatever you eat, your body think you need glucose, your liver will already convert. So you cannot control that. So don't worry about you eating sugar going to hurt your tumor. Nothing like that going to happen. If you need a sugar, your liver is called gluconeogenesis will kick in. Well, automatically, your brain needs glucose to be functioning. If you don't have glucose, you get retarded or you get confused. Mm-hmm. So nothing try to alter that. You know, like everything's modest. If you just eat the right amount, your body will take care of it. When you need it, your glucose generation will kick in the liver.
There used to be an old adage, starve of cancer, feed of fever, which sort of is the basis of this concept, and the idea that depleting yourself of sugar was in existence a long time before the PET scan and the knowledge that the PET scan was dependent upon the higher metabolism of cancers. Actually, it won't work for many reasons, and for example, we know that serotonin derives basically from tryptophan, as I showed in my presentation. And so with that idea, an effort was made to treat the symptoms by starving a person from tryptophan. And therefore, with the hope or expectation, maybe they couldn't make serotonin then and wouldn't have symptoms. Well, the result is they become emaciated. The body still cannibalizes its own tissue to extract tryptophan, and the end result is you get worse and you don't improve your carcinoid, and the same thing holds for avoiding sugar.
Okay, I think it's going to go to Dr. Liu. I'm sorry, go ahead. I'm sorry, Dr. Dietz.
I'll be brief. Different.
I'm kidding.
Where's the timer? Octreotide, some of the treatments that we use for carcinoid can cause insulin resistance, and we do follow A1Cs, glucose intolerance in patients who are on these medications because it predisposes you to developing diabetes and metabolic syndrome. So coming from a different angle on this question, I would say, yeah, I mean, I really do prefer that my patients do what was recommended, you know, in moderation, nothing in excess, you know, limit your carbs, marry your carbs and your proteins to prevent insulin resistance. And because some of these medications set you up for that, and so you're at risk anyway from the get-go being on these meds, and if you dial up the sugar and the carbs, you're going to be even higher risk.
Dr. Dietz is quite correct. It should be pointed out that one of the side effects of long-term octreotide or lanreotide is to increase blood sugar level, and consequently many patients who are not diabetics, or perhaps just latent diabetics, will have their blood sugar levels go higher, and they may become slightly diabetic on these drugs. And also, the same thing happens with affinitour, everolimus, which increases blood sugar. So it is sensible to reduce your dietary intake of sugar if you're in either of those situations, but it doesn't mean you can really help the tumor by starving yourself.
Okay, this is going to be for Dr. Liu, I believe. If the trial study for PRRT is not available in the U.S., what exactly will be conducted at several U.S. sites to promote that trial?
Well, this particular trial is just for small bowel mid-gut carcinoids. So there's no promotion. You go to the center, and either you get referred or you don't. So it really comes from you guys. The website.
Okay, are the 3, 5, and 10-year survival statistics based on the treatments of 10 years ago? Haven't things gotten better since then?
Yeah, that's one of the very difficult things about evaluating the data that we have. So if you look at this quote-unquote SEER database, it's kind of a generic database from the federal government, and it is certainly not accurate. And yes, the therapies and philosophies and treatments have changed over the years, so I think it's an ongoing process. So all you can do is just kind of collect our data and follow it as it goes along.
At the European Neuroendocrine Tumor Society's annual meeting this past spring, Dr. Oberg commented on a study which he did with your organization at Vanderbilt, both carcinoid neuroendocrine tumor centers, where patients would get better level and more thorough treatment than in the general medical public area, and he showed statistics indicating a better and longer survival under such quality care.
Okay, next one. If you are not highly somatostatin receptor positive, but you do light up on 5-HTP, can they attach lutetium-177 or another isotope to the 5-HTP mechanism?
No.
5-HTP scan measures a different type of chemistry and uptake, doesn't measure the somatostatin receptors.
All right, for Dr. Liu, does the NETTER trial include crossover for randomized control patients
No.
on sandostatin only who fail response?
No.
That would mean, therefore, that if 50% of the patients that enter the trial who are randomized to receive the sandostatin rather than the active radioisotope are not going to get treated and don't have an opportunity to be crossed over to receive treatment after the number of months that they've served as randomized subjects.
Correct. Now,
Do they have the option to quit the trial?
yes, because they've essentially finished. Actually, he's 100% right. Essentially, once you've progressed, you've finished the trial. Now, we will try to follow patients to see what the overall survival is, but we can't control you once you've finished. So if you've progressed, then you may move on to Basel, wherever.
All right. Can carcinoid tumors ever develop in retina? Can carcinoid tumors ever develop in retina?
You're older than I am.
Very, very rare. Very rare, but it does occur. I've seen 2 or 3 cases, and the Wills, I believe, Eye Institute in Philadelphia reported 5 cases, as I recall, a few years ago when I queried other experience. So it's extremely rare, but happens.
Actually, the place it can show, though, is in what's called the retroorbital space. So you can get, so in general, the true retina is within the visual complex of the eye. Okay, so it's in the back of the ball of the eyeball. The most common rare disease that comes here is actually melanoma. that's the oncologic thing that really is that we think about from the retina. But you can get tumors that appear in the back of your eye, in the muscles, in that soft tissue space, and that does happen. I've seen that a few times.
Retrobulbar carcinoid metastases, which there's some fatty tissue behind the actual globe that makes the eyeball, seems to be a favored place for metastases for non-gut carcinoids, and it often presents as proptosis. The eyeball protrudes like we see in Graves' disease from the thyroid. And that's bad news. But on the good side, in all the cases that have been seen, it's very sensitive to external beam radiation and has responded very well to radiotherapy.
All right. Can dye be used to see lymph node involvement for lung carcinoids during surgery?
The blue dye mapping can be used in the lung carcinoid. I have done this. One of my partner, Dr. Smith, have tried that, and he tell me it works fine for him.
Let me just make a comment though. In general though, it's much better when you have your lung operation for them to do a thorough lymphadenectomy, which means going inside there and getting all the lymph nodes. The major problem that I see with lung in particular is they think that carcinoid's benign, so they just cut out that little tiny little piece and don't look at the lymph nodes, and then the lymph nodes are positive, and that's where it comes back. That's the common issue.
All right. Is there any connection between carcinoid and neuropathy? They don't mention where the neuropathies might be cited. Connection between carcinoid and neuropathy.
There is no specific neuropathy related to carcinoid syndrome or carcinoid, but there is a myopathy, an arthropathy, in other words, a muscle degeneration, and also joint problems. They are rather responsive to octreotide, sandostatin. They're not common, but they do occur.
One of the big problems with neuropathy, though, unfortunately, is that patients who have carcinoids and are mistreated and are given big old heavy-duty guns of chemotherapeutics will develop neuropathy secondary to platinum.
Okay, for Dr. Dietz, how can you detect intestinal adhesions, and what modality is best?
Typically, this is my question. Stop it. I'm glad I have a room of witnesses to this behavior. So the intestinal, you can talk next. The intestinal adhesions, typically patients will come in with bowel obstructions, abdominal pain, cramping, and that's how they present. This is not something that necessarily we pre-image for. In patients with known carcinoid, they have been imaged multiple ways. As far as surgically evaluating the adhesions, I defer to Dr. Liu.
Well, I think the major problem with small bowel carcinoid is actually what you develop. You develop something called a desmoplastic reaction, which is basically it scars down the bowel. So this is the big problem actually with carcinoid, and you get what's called chronic small bowel obstruction. So essentially, normally our bowels are very free floating because when you're eating your cheeseburger or whatever it is, it needs to get through. But if you have scarring and that tumor kind of locks it down, your bowels don't move so well. So you have one bad pistachio and it gets stuck. It doesn't travel all the way through. And then on top of that, if there's a little bit of congestion from the venous obstruction or something like that, your bowels just aren't happy. So a common complication is chronic small bowel obstruction and eventually small bowel failure.
The worst of the whole picture, the spectrum, about 4% of patients in our experience toward the end spectrum of their disease process develop a condition called cocoon formation. We still don't understand why that happened. It's almost sudden the fibroblasts in the patient's body just try to take off, try to contain the disease by making a compartmentalize of the tissue. They were making an envelope around intestines, sometimes was enclosing the small bowel only, sometimes the colon, and sometimes the vena cava. And we see a few patients, the thing tip off, patient develop this cocoon formation as they come in the lower leg like blow up like crazy, and everything else looks fine. And then we look at CAT scan, looked at retroperitoneum, look like thickened, and it become a thickened tissue compressing in the vena cava to prevent the blood from returning. And then we make the diagnosis of the so-called cocoon formation. The bad news is we operated on about 10 patients with a cocoon formation when we didn't know what this is about. And only one patient was successful, get away after surgery for 18 months. The rest of the patient didn't do quite well. So I presented a paper, wrote it up, published in Pancreas to warn people that long-term carcinoid patients develop bowel obstruction before surgeon operate on should really do an imaging study, look at CAT scan to make sure their peritoneum are not getting thickened. And sometimes they may have to go through imaging study to make sure the bowel is not compartmentalized in some area and looks like a wall off, become a bag, and we call it cocoon formation.
Okay, this was directed to Dr. Wang, but I think all of the doctors here are going to have fairly the same answer because they're pretty accessible. Dr. Wang, how does one start wanting to see you? Do you need first to go to Dr. Waltering? I'm not going to go about the recommendations. I'm just asking the question.
Well, the way we set up is Waltering usually as if the front runner, he see patient, and me and my partner, we operate on people. But I also tell my office that if the patient who have a special interest want to talk to me directly, I don't see why not. That can be done. So if you want to see me, in particular bypass the other person, you can just tell my office, say I meet Dr. Wang at the conference and I'd like to see him in person. Just have to tell them that. And sometimes they will tell you, say, we don't do that. Say I talked to Dr. Wang. He said he will see me, and just say that.
I'm just going to add here real quick. All of these doctors who are here today, and all of the neuroendocrine tumor doctors, they're amazingly available. I mean, I just find it amazing. You go on the internet, there's their phone number. It may be, schedule an appointment. It may be that, but you can get to them. It's not like some of the health cares or certain places where you happen to you want to see a doctor who's a specialist in neuroendocrine tumors. They're a great cancer center, and no, you don't see the specialist in the neuroendocrine tumor. You see the next doctor who's on the rotation, who's next on the list. So, and that's a problem with a couple of places, one in particular that I know of for sure. I won't mention any names, but, you just happen to get, and that could be a good doctor, it could be a bad doctor, it could be a terrible doctor. And if it's not serving you, it's a terrible doctor. That's the bottom line. But most of these doctors that are here, and any of the neuroendocrine tumor doctors, they're amazingly accessible, amazingly. I mean, you call them up, they call you back. It's as simple as that. Dr. Warner?
The Carcinoid Cancer Foundation's website, carcinoid.org, lists a list of available carcinoid expert physicians or carcinoid-friendly physicians on their website in almost every state in the country, and we also can help find such doctors abroad when necessary, and that's a good place to start.
Okay, this is a good one. I like this one. I will be traveling on it's specific to a person, but you know what? All been there, all done that, maybe want to do that. I'll be traveling on a cruise ship visiting many ports. How can I control my bowel movements so that I can do day-long sightseeing excursions? Not seasickness, bowel movements. That's my problem, seasickness. Anybody want to take that?
If I understand the question, it's saying if, presuming I have carcinoid syndrome, but I'm going to be in a situation where I don't want to have to run to the bathroom or have it immediately accessible, what can I do to really control my bowel movement?
But the ocean is nearby. Should be able.
Well, we can take extra sandostatin, that might help. And then there's a bunch of general anti-diarrheal drugs, the commercial names, Lomotil, Imodium, and finally your doctor can prescribe deodorized tincture of opium, DTO. They're drops which are very constipating and will be of some help, but that's not really getting at the root of the problem. but it may help for when it's necessary in this capacity. The other thing is to avoid alcoholic beverages and to also avoid foods that are fatty, greasy, or oily, and also to avoid highly spicy seasoned foods. That will help a bit. Finally, if you're on sandostatin or one of the other drugs such as lanreotide, we can give you a pancreatic extract supplement which will replace the pancreatic digestive enzymes, which will be a bit inhibited normally as a side effect of your somatostatin analog treatment, and that may also help control some diarrhea.
Just to follow up that, that's great. Some patients do respond really, really well to a medication called Zofran, which is ondansetron. We use it for nausea, and that seems to help. I don't know how much, have you tried that?
Say again the name?
Zofran.
Oh, Zofran, yes.
Yeah.
That's ondansetron, which is a serotonin receptor 3 receptor blocker. There are a variety of serotonin receptors, just as there are somatostatin receptors on the cells. Normally, everybody has these serotonin receptors, and Zofran, which is used mainly against nausea, and it's fairly effective, which may be the nausea that may be associated with chemotherapy, will often control diarrhea in carcinoid syndrome, which may not be otherwise controlled. It's a very expensive way of doing it, but in a pinch, it may be helpful.
Well, the other thing that actually really helps is rescue octreotide. So you can, before you go on your cruise, you can try some of the rescue shots, and that may last you a good 6 hours while you're going on tour or whatever it is you're doing. So, and you can pretty much take that, I mean, carefully, but you know, you can take a fair amount of it. So that's another good option.
All right, this kind of dovetails in a little bit. How many milligrams of sandostatin, I'm assuming the LAR? Oh, I'm sorry.
I don't know if the doctors would agree, but I take Colstid, C-O-L-E-S-T-I-D. It's a drug for high cholesterol, but the side effect of it is to bind the liver.
Oh, the bile salts?
Yeah.
Is that the one that comes as a powder?
Yes.
Yeah, so this drug, the typical name is called Questran.
Questran.
Yeah, Questran. So just to dovetail into her answer is a bile salt binder. So a lot of the people who've had the tail end of their intestines removed, they don't absorb the bile salts anymore, so it just kind of spills into their colon and it gives them diarrhea. Hence Dr. Wang's technique. But you can take this kind of sandy stuff and it binds it up and it kind of solidifies it so it doesn't give you so much diarrhea. We call it Questran. I guess that's what I call it. Might be another. Cholestyramine is the name of the drug.
The one trade name of cholestyramine, which is the generic name.
But you should try it at home before you.
And it will help in some cases because the bile salts are normally reabsorbed as they pass down your intestine. They're secreted as part of the bile from the liver.
It went off. The button's on the bottom.
The Questran binds the bile salts, which are being passed through the intestine too rapidly because of the rapid transit of intestinal contents because of the stimulation by serotonin. And so these bile salts will get into the colon where they are irritative and they impair the absorption of water in your bowel content, which augments the diarrhea. And the chelating or binding effect of the cholestyramine will help by taking up the bile salts before they can get into the colon where they're irritative. Many patients will take all these modalities and use the whole battery of things we've mentioned and can get at least temporary benefit.
Dovetailing into that, how much sandostatin LAR should be given monthly? How many milligrams?
Well, the standard, according to the package insert approved by the FDA, is 30 milligrams, but most people are now treated with 60, and that usually is the highest it's convenient to give. But a few are getting by with 20. It comes as 10, 20, and 30 milligram packets. Problem, if you have to take more than 30, then you need 2 injections. And as you all know, those of you who have it, it's not a pleasant injection.
After having yttrium 90 done on my right lobe of my liver, my interventional radiologist did a PET scan. Was it necessary, and does it tell him about the effect of the Y90 procedure? They don't say how long after.
About a month.
About a month? Okay. About a month after.
I would say no. In general, FDG PET scans, which are the standard PET scans that are performed, are not highly useful, I would say, in neuroendocrine tumors because they tend not to take up glucose because they're so slow growing. Now the problem is, now if you've got, so yttrium 90, which Dr. Warren talked about a little bit, is when you spray the radioactivity into the liver. So the other thing too is that yttrium 90, PET scan is very, very poor for discerning size. So you're much better off getting a true, good, high-quality cross-sectional image, such as an MRI or a CT, depending on whatever it is, into determining how your tumors are either shrinking or growing or whatever is happening. Then the other thing to do is to set markers and to look at your symptoms to see what the difference is. Yttrium 90 is particularly powerful for people who have symptoms. There's been some control of tumor growth for about a year, okay, and so that's kind of how it works out. So in general, getting a PET scan a month later is not the usual kind of pathway that we take.
I'm just going to add something to that. Something we've found or read about at various times is doctors order some of these tests, and sometimes the doctors have interests in the place where the tests are being done. So it's kind of like, okay, well, if I order an extra PET scan, my wife can get the heated leather seats on the new Jaguar we're ordering. And I'm not saying they're all like that, but you do have to watch sometimes with some of that for that. All right, for Dr.
The PET scan really using the rationale because the tumor is much more active in growing, so on and so forth. And we talk about again and again, in general, neuroendocrine tumor are very slow growing, Ki6, 7 low, so they don't pick up much glucose activity. So really, we don't even recommend PET scan in most of the patients. I'm very kind of surprised to hear. The only time we order PET scan is we are. I mean, just that means we are failing the audience and failing to the public. We are not educated to other physicians. The slow-growing tumor, you should not even think about the order PET scan. We should really, that's why the medical cost of this country becomes sky high. Everyone just order tests and don't even worry about who's paying the bill. And you and me, everyone's paying the bill. So it really make noise. Say, those are inappropriate tests to order to begin with. Okay, we do order that. Having said that, when you're a rectal carcinoid and did not light up arterial scan, we occasionally do go to the PET scan because that will tell us that we are dealing with a different group of animal. In general, if the tumor light up on PET scan and don't light up on arterial scan, I have to tell the patient, say, I have bad news for you. Your tumor is not a regular carcinoid, it's a very aggressive one because arterial scan did not show activity and yet PET scan light up. So we only order PET scan in someone with obvious disease we know is there and did not light up on arterial scan, then I use that as another information to determine if this tumor is an aggressive one.
I think Dr. Wang would be a great Secretary of Health and Human Services.
Vote for me.
There you go.
How many times can you go for the Y90?
The question is, how many times can you go for the Y90?
Many. So one of the great things about Y90 is that it's a non-occlusive therapy. So what that means is when they shoot the little tiny beads, they're small, so they don't block the actual vessel, right? A bland embolization or a chemoembolization actually blocks off the vessel, so it's shut down, so you burn bridges. So you can get Y90 actually several times if it works for you. The problem is it scars the liver at the time.
Do do ask your radiation oncology or interventional radiologist who is doing this, how many they have done, what their outcome is. I have 3 patients in the last 2 months developed liver cirrhosis. Apparently, the radiation dose was not even either calculated right or something. They have a radiation-induced hepatitis and cirrhosis. 3 patients in a row.
Wow.
After how many?
From where?
But the way I look at it, this is an unanswered question. We always. This is an unanswered question. Remember, we always look at pathology to say how much vessel in each high-power field the pathology look at it. And I think maybe some of the patients have too many vessels in the particular patient. You will carry too much radiation into that patient and burn your liver. So I think we need to really look at patient very carefully. Say, the patient who has a poor outcome, I'm pushing one of my residents try to find out, those patients have many particular features on their pathology. Maybe they have too many vessels in there and bring so much radiation there, should not be going that area and ended up burn the background.
Okay. My primary tumor was found in my cecum. It's been removed. I have liver mets and was treated with Y90 on both lobes. Recently, there were 2 new tumors discovered on my intestines, right side again. Does that mean I had a second primary tumor?
It's possible. It also may be that these are tumors which have developed through lymphatic channels that Dr. Wang has commented on.
I think most likely there's a lymph node left behind, and we're not trying to condemn any other surgeon done this before. I never noticed before either. I was taught to do 5 centimeter, and this is how you do the margin. And as I said again, I finally started doubting myself. See, and I've been taught right why my human eyes can serve me to do a cancer operation without using blue dye to help me. And I think, and one of the things I did not make that very clear, when I do the mapping, and when we look back, all the patients have recurrent disease we operate on. Usually the recurrent disease are right adjacent to the previous resection site or in the neighborhood. So the best explanation is the lymphatic, the cancer escape route was not mapped out.
Okay. Has the approval of affinitour and suitant affected the course of treatment for NETs and PNETs? Are there any new statistics on patients being treated with affinitour suitant in regards to survival rate?
Please say the last part of that.
Are there any new statistics on patients being treated with affinitour or suitant in regards to survival rate?
Well, these drugs achieved FDA approval because they showed an improvement in progression-free survival, although statistically the overall survival rates were not improved. But again, treatment at the centers that specialize in neuroendocrine tumors, the evidence, as you heard us cite before, is that life is prolonged when multiple modalities are used sequentially with a personalized choice of which one when. It's not a matter of one drug and that's the way to go and that's the whole answer as the magic bullet. It's rather everything that's put together in the order in which it's given.
I'm going to add something to that, Dr. Warner, if I can, from our experience or my experience in talking with patients. What we find, or I found happening for a while, it seems to have dropped back a little bit, was a lot of doctors who don't know anything about neuroendocrine tumors who are now treating what I call medicine by internet. They actually go out there, it's like, oh, patient comes in, oh, you have a carcinoid. They type in carcinoid. What comes up? The newer medications, affinitour, suitant, I forget their generic names, which I should be using, and I'm not, bevacizumab, and I can't remember the other one. But thank you, or everolimus. Okay, what's the other? Bevacizumab is Avastin. Okay, sorry, I got my generics mixed up. But in any event, what they do is they type that in. So what do they get? They get a lot of the new stuff that's being published, being I won't say hyped, but it's high on the Google list because there's some money being put into it to get it ranked up there higher. And so now they start treating with, oh, this is the latest and the greatest, this is what we're going to give you, and it may not be appropriate for their particular case. And unfortunately, it often fails because it's not appropriate for their case. I'm not saying everybody's doing that, but we seem to get a bunch of them for a while there. It seems to have slowed up a little bit.
I think the bottom line of that lesson from Jim is basically you should see someone who's really a super hyper subspecialist in neuroendocrine.
Yeah, exactly.
There's a lot of subtlety to this. I mean, there are so many different flavors. I mean, I say this all the time. There's so many different flavors of carcinoid neuroendocrine that you want someone who sees, like, you know, if you come to my clinic on Thursdays in Nashville, you'll see 17 of them in the waiting room, just bang, 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 bang. And each one's a little different.
All right, Dr. Wang, is the blue dye the same that is used in breast cancer surgery? And have you published anything to entice other surgeons to do the same?
Yes, the same dye, and the paper published in Surgery 2010 January. You should be able to, if you put a Google my name, the paper should come up, and you should be able to find it.
Because there's only one Dr. Wang in the world.
No, there's only one good.
Wang, one, Lu, nothing. All right, on gallium scan, what's the availability of it? And if most patients can't get the gallium scan, are they being underserved?
I can't. Oh, man.
I like tossing these hand grenades once in a while.
You know, there is an unfortunate standard of care in the United States, and it's limited by technology and various things. There's the truth, and there's what is available. And unfortunately, you know, as much as I can, I try to deal with the truth. And but sometimes you have to deal with what's available. And so the question is, are people inaccurately treated because of the technology available? The answer is probably yes. Are we working really hard to change that? The answer is definitely yes.
The other part of that, I got another question, just follow that. Is it covered by insurance, the gallium?
So no. So in general, the PET part of it, the machine part, the technicians pushing the buttons and those things, that's usually covered by insurance. It depends on whether or not your insurance company allows PET to be part of neuroendocrine in general. So if you got that PET scan, it'll be covered. But the gallium part is experimental, and so it is not covered by insurance, period.
For Dr. Wang, what kind of chemotherapy do you use during surgery and after surgery?
I don't do any chemotherapy after surgery. I'm not a medical oncologist. I just use chemotherapy intra-op just based on the assumption I must leave some microscopic disease behind, and I like to enhance my work and to have a long-lasting results. So I look at the tumor we study from all the patients we operate on, and I pick out the most sensitive drugs, the 5-FU. And also I use 5-FU to avoid the FDA application process. When I was first using this, my hospital tried to stop me, say you cannot use that, you don't have the data to prove it, it's not FDA approved. So I finally have to say, who tell you I'm using chemotherapy? I'm using this to stop the bleeding. So now I have more than 300 patients have this therapy. Now I can write my own paper to prove this is effective. So I'm going to backdoor to bypass the FDA.
And they're not bleeding.
And they're not bleeding, yeah.
They really help stop bleeding.
All right, for Dr. Warner, is there any hope in the future that sandostatin LAR will be in a pill form or less painful?
It's unlikely to be a pill form, but there are some varieties of it being studied that may make administration easier. For example, there's a subcutaneous implant that was under study that is a tiny little cut made in the skin, and the medicine implanted under the skin to last for many months in its effectiveness. I don't know where that research project is at present, but I know it was underway several years ago. In addition, there's a variety of of the drug was being studied, in which an injection would last for several months. And then, of course, we have a pasireotide, or SOM 230, which is the next generation that will be attracted to 4 of the 5 somatostatin receptors, and which may be more potent. Although that will have to be given by deep intramuscular injection monthly at the present time. And then finally, the somatulin, which is the trade name for long-acting lanreotide, which is available in Europe and is on the trail towards getting FDA approval in this country, is given by a subcutaneous injection, which, in spite of the fact that the needle is rather large, is less painful than the octreotide, than the sandostatin LAR injection.
So I just want to say a couple things. First of all, the sandostatin shot doesn't hurt me at all. So just, I think, let me narrow it down a little bit. So someone clearly thinks about this oral octreotide. You may have read about it, heard about it. It's from a company called Chiasma. And they were recently, I think, partnered with Genentech, I think, or Roche, maybe Roche. Anyway, so that's quite a ways away. Okay, so they're doing some clinical trials in it for certain types of other types of disease processes, but it is not probably going to be anytime quickly available, because you still have to take the pill like 3 or 4 times a day because of the dosing of it. So it's not going to be so simple. So I don't think so. And more importantly, it's going to have to be proven in order to be effective against, you know, kind of the symptoms for carcinoid, which is not so simple either. So just be aware of that. One other thing too is that some people do try what's called the octreotide pump. So, you know, you've heard of an insulin pump before. Some people do put octreotide into it, and that may be a little less painful.
Just a quick fun one. Dr. Liu, do you ever sleep?
Not when my Facebook page is open.
ADD, he cannot sleep.
Yeah. Well, I gotta tell you, you know, I have to be honest. I have 3 children at home, and my wife works much, much harder than I do, so I have to give her credit. But yeah, I try to sleep when I can.
All right, this was something we were going to do at the end, but I'm going to do it now, since otherwise I might forget. Looking to find others who have had PRRT. How about a show of hands? If you've had PRRT and you're willing to talk to people later on after this event in particular, would you just please stand up? You can identify yourself or whatever, so people can see who you are, and they can seek you out later on. And congratulations to each of you. Yeah. To tell the truth. Okay. Thank you so much for volunteering for this, very honestly. I appreciate it. Okay. Oh, another hand grenade. Dr. Warner, do you agree with Dr. Wang's philosophy of surgery, surgery, surgery? Careful.
I don't agree with any generalization. The treatment has to be customized for each individual. I do agree that surgery is not often enough used, and that there is a time when lots of surgery is appropriate, but I think it's dangerous to make a generalization and just try to apply it to all cases.
One of the reasons I recommend surgery as a first-line therapy for different reasons. I never say that's good for the liver, but I think primary and lymph nodes should be done. We learned this from many different cancers, other cancers in the past. Breast cancer, when you metastasize to the liver, to the bone, the surgeon will never touch any patient's breast, because they say the horse is out of bone, too late to do anything. In reality, the concept of pendulum have swung complete backward now. Now, even with metastatic breast cancer, the surgeon will recommend to remove the breast disease itself, and for several different reasons. Number one is a new metastatic lesion will not come out from primary because you killed the bin Laden already. The second thing they think should be done is new genetic mutation may not happen. The primary tumor most likely is where the new mutation keep coming out. So in other words, if the patients respond to chemotherapy already and now have a new mutation come out, the chemotherapy may fail. And the third reason, they think if you remove the primary, then the rest of the chemotherapy will much more effective go to the metastatic side instead of wasting all the drugs on the primary side. Based on this, I cannot say it's a complete equivalent of what I'm doing, but I think that theory has some validity, maybe to remove the primary to prevent further tumor from seeding, to make the treatment more effective. And that's why several patient audience ask me, say, should I go for PRRT or surgery? I said, those are not mutually exclusive. I said, in my mind, if you are a good surgical candidate, you have primary tumor, the lymph node in the small bowel primary lymph node or colon or stomach, I think by surgeon know what they're doing to remove the primary, to remove the lymph node, to reduce the tumor burden, and to make other treatment more effective is not a bad idea. At least now you maybe potentially eliminate further disease from coming out from the undealt with primary. And I think my statement is backed up by the study from Sweden, from Germany, from Oregon, from Mayo Clinic, and from my own data. If you just remove the primary, the patient do better than without surgery. The patient have combined removing primary and lymph node better than just remove the primary only. And you address all three lesions and all three components, the regional disease, local disease, and metastatic disease, patient even doing better. So I think each step is a different way. And I never tell people, say, liver surgery is always a surgery, it's first choice. I never say that. But I think primary and lymph node, I'm gonna stick to my gun. And he and me, I will come a long way, good friend. But I have to say, I'm standing on my side of camp. I recommend people, if you are a good surgical candidate, you have a primary tumor, has not been addressed yet, find someone to address it.
Okay. This is a problem I deal with. Why aren't more doctors more aware and informed about carcinoid so they don't make an assumption that their patients are just hypochondriacs and also dismissing their symptoms as common sicknesses? Dr. Lou is like, give me the mic, give me the mic. Mike.
So does everyone know why zebras are the symbol for neuroendocrine and kind of rare cancers, or rare diseases really? The reason is because in medical school, we were taught when you hear hooves, you should think horses. What that means is if someone has a cough, you should think pneumonia instead of miliary tuberculosis immediately, right? The problem is that every now and then it is miliary tuberculosis, and every now and then diarrhea turns out to be carcinoid. So just imagine, okay, and I don't envy this position, but just imagine you're a primary care physician, okay, and you get a patient who walks in with diarrhea, and the next one has diarrhea, and the next one has diarrhea, and the next one has diarrhea, right? How many of those are actually going to have carcinoid, right? It's actually a relatively small number. So it's not so easy to figure out. I think what's better is certainly to increase awareness, which we are doing today, and it's up to you. And look, let's be honest, this is a crusade, right? And so you are all soldiers in this crusade, and so we have to get out there and teach our doctors and get them. We have educational opportunities. We're putting foundations together to bridge that gap. And so we need to get these doctors well educated so they're aware of it. So you don't want to miss the patient who actually does have it, because the workup is actually not so complicated, it just has to be done. But at the same time, they have to have a good, strong suspicion, just not let diarrhea go for 3, 4, 5 years. I mean, yeah, sure, maybe it takes 2 months to figure out. That might be 3 months to figure out. But you know, there are many people who go on for 7 to 10 years before they're actually diagnosed. So it's all about our being out here, all about the work of Jim, and all about the work of you guys, all the work educating our own physicians in Novartis Oncology and various else. It's a crusade, and we're all part of that war.
And another problem of this issue is meeting like this help patient and family member, but the message may still not go into the medical community. And I recognize that fact very early on. So since 2009, I haven't at least present 2 to 5 abstracts in all the international meetings, like ASCO meeting. I always, 3 years in a row, they take my paper. American College of Surgeons, 3 years in a row, they took my paper. American Endocrine Society Surgery meeting, they took 3 years in a row, taking my paper. So this, what I'm doing is I want to use the opportunity to let other surgeon or other physician, GI doctor, medical oncologist say, hey, pay a little bit of attention here. We are working on this. We come up with something new we like to share. And it has been a slow, painful progress, but the progress has been made. I tell you, when I go to the ASCO meeting the first year, nothing happened. The third year I went there, they designated 2.5 hours discussion for neuroendocrine tumor. I was ecstatic. I cannot believe they will save 2.5 hours for a 6,000 physician annual meeting for this group of patients. So I was very flattered. And last year, things even getting better. American College of Surgeons have a 70,000 membership. They call me and say, we'd like to see the lymphatic mapping technique. We think it's important for you to come out to the podium to show how you do this, and maybe we can learn from this. And we don't want you just come up here to talk. We want you videotape it. And they give me 25 minutes to put my videotape up there. As a matter of fact, if anyone wants to see how this is really done, the American College of Surgeons archive, the video archive, you should be able to find my name and you can see the videotape. So we working as a group, I think all together we should go out, not just come to the meeting like this. We also need to go to the meeting for medical specialists, for medical professionals, so we can start to educate our colleagues and have the word spread around. Thank you.
You know, and just let me just piggyback on that. One thing you should do is you should go back to your physician and say, hey, do you think you could maybe join the North American Neuroendocrine Tumor Society? That's kind of our professional society for the MDs. And maybe, you know, instead of giving them a big basket of fruit or candy, you can maybe get them a membership to the organization, and maybe they'll come to the meeting. And by the way, the 2014 meeting is in October in the great city of Nashville, Tennessee. So encourage them to come because it's going to be a great party. I promise you it's going to be a great party. But more importantly, it's going to be a real opportunity for us to educate people. We're working on, you know, really strong educational programs to get people, because, you know, it's great that we talk to the specialists and we talk to each other, because I love seeing Dr. Warner, but at the same time I really want to talk to your doctor. Yeah. I want your doctor to come so we can hang out and talk and teach and learn about things. And maybe they only have 3 or 4 patients, but you know what? In the next few years they're going to have 8, 15, 25. And so if we get ahead of the curve for all of you guys, it's a good start. So consider it.
As a side note to that, by the way, for this conference, a lot of our people here in New Jersey, we asked, who are your doctors that you want to know about this? And I got a list of a bunch of doctors. I sent out about 24 letters inviting them to this conference. We would foot their bill to be here. Free lunch, guys, free dinner afterwards even. Okay, we'll foot your bill. I got 1 response back out of 24 of them. Not even so much as a thank you very much, not even so much as go ahead and cross the street if, you know, against the light and leave me alone. Nothing. But you know what? I'll keep writing letters and I'll keep wearing them down, and they're going to be tired of hearing me for that. But yeah, that's some of the problem we have. Doctors are set in their ways.
The other thing you guys may try is, if you have close with your physician, you can recommend to your physician, say you guys have a grand round. Why don't you invite Dr. Liu to come out, give us a talk about the neuroendocrine tumor, or invite Dr. Warner to come out, give a grand round talk on a certain subject. And I'll tell you a very touching story. 2 years ago, I was invited to Virginia Medical Association to give a talk, and the story was almost amazing. I saw a patient came to me after a local physician in the Virginia area sitting on a patient for 14 years. And they did really not treat her right, and eventually she found us, and she found me, and I take on the case. We did a surgery. Surgery didn't go very well as I would expect it. It's just the disease way behind the game. Ended up, she succumbed to the disease. So of course the family was very upset, and they was all hostile. They think they should sue the hospital and the whole 9 yards. And all of a sudden, then they have a turn, and they talk to me. I said, don't blame on your doctor. They don't know anything about this. No one teaches them in medical school. We never talk about this. We never think about this. So if we never think this could be a problem, this diagnosis never will show up on your radar screen. I say the thing is education is more important. You know, guess what? The family just completely blow me away. They say, okay, we're gonna do something different. What they did is they went back to the hospital. They demand, say, we're gonna drop the lawsuit against you, but we want you to do one thing. We want to invite Dr. Wang to come up to Virginia Medical Association, give a luncheon talk, and we'll drop it. And they really did it, and they went to Virginia area, the Whitewater area. They knock on door to door to every single hospital, say, we're inviting an expert from New Orleans come to talk about carcinoid. And the hospital happily helped them out with all kind of financial, the video, audio set up. I was completely blown away. I went there, I had 150 physicians from Medical Association to listen to my talk. And I was completely taken away. And then all of a sudden now, the Virginia people, the physician know, and all of a sudden we got a whole bunch of referral come down from Virginia. So you guys can make difference. If you know someone, you know, in the administrative level, say, hey, you guys spend money to invite outside speaker, you know, why don't you occasionally, once a year, invite Dr. Warner, Dr. Rue, or me? You know, any one of us will be happy to come out to give grand round and to spread word.
All right, a couple, just real quick. What's the status of pasriotide, Siam 230, for those without receptors for octreotide?
As far as I know, the results of the long, multiple-year study are in the hands of the FDA, and it's going through channels. I can't say more than that. The company, Novartis, who makes it, has not made any announcements, and they're not likely to do so while the FDA is still deliberating on it. And perhaps Eric knows more about it.
Well, just so you all know, pasriotide is the next generation of octreotide, and like Dr. Warner says, it binds particularly well to receptors 1, 2, 3, and 5. There are some data with the study looking at symptom control, and it was unfortunately, was no better than symptom control for symptom control. It was no better than octreotide, but it was more poisonous. There's more toxicity to it. It made people's sugars go up more. So that's not so great. There's a trial going on right now looking at high-dose pasriotide for tumor control, like you do for octreotide, and I think that's still in the going on phase. It has been approved, though, for acromegaly, which is a pituitary disease, and it does suppress very well for that. And there are other trials going on looking at for other kind of diabetic metabolic things like dumping syndrome and things. So it's under investigation. But right now it's currently only approved as the sub-Q version, not the long-acting version, for acromegaly.
Okay, last question, because all we have. If I didn't get to your question, my apologies. I got through about half of them, and there's just so many of them here. Some of them were good. I tried to pick the ones that I thought might have the most interest with that. What precautions are needed before dental procedures such as a root canal? And I think they're referring to epinephrine in the epi that's in the Novocaine.
Well, do you want to answer that, Dr.
Patients with carcinoid syndrome can have their syndrome symptoms provoked by stressful situations which cause the endogenous release, that is, from within their own body in response to the stress of epinephrine or adrenaline-like substances, or if they're given it by injection. For example, dental work often uses epinephrine in the anesthesia that's injected, and this can provoke carcinoid symptoms or even carcinoid crisis. Therefore, even if you've never had carcinoid syndrome but have a known carcinoid tumor, and there's a suspicion of a tendency towards symptoms, you should be given a booster shot, a rescue injection by subcutaneous injection of octreotide before you have whatever the procedure is going to be, anything such as dental work or a minor surgical procedure, even colonoscopy, for example. It's a safety factor, and in many cases it's unnecessary, but we have no way of telling ahead of time with certainty who might be the unlucky person, never having had carcinoid flush or low change in blood pressure associated with their tumor, but yet having known elevation of serotonin might be subject to this type of serious reaction.
What about Novocaine, doctor? If you're having a filling and you got Novocaine.
Well, Novocaine that the dentist uses often comes with epinephrine in the preparation. So you have to stipulate to the dentist to use no anesthesia with epinephrine. They can use that too.
I have to say dermatology too. You know, if you go to the dermatologist.
Yes.
Okay.
It's easier just to tell everybody across the board.
No epi.
Pharmacy that I'm allergic to epinephrine.
Right.
Just let it go like that.
Well, there isn't any true allergy to epinephrine. It's often listed as allergic reaction in a carcinoid patient, but it's not an allergic reaction. It's a provocation of the carcinoid syndrome. The carcinoid syndrome is like a gun with a hair trigger, and the epinephrine is the slight pressure that gets applied to that hair trigger and can trigger off this serious reaction.
Okay. Judy, go ahead.
Well, I just want to say on behalf of the New Jersey Carcinoid Cancer Network, we are so very grateful to have these renowned physicians come and speak to us today. So this is just a small token of our appreciation. And thank you again.
Okay, I want to thank everybody for coming. I really appreciate it here. I hope you learned something. If you didn't, where were you sleeping? I want to know because I'm tired. Okay, no, I don't mean it that way. It's been fantastic to have everybody here. I hope to see you all again soon. If the people for the PRRT, if you want to meet in the corner over there, I think that might be best. We have to clear this room of all of our equipment in about the next 20 minutes. So there's going to be people up here ripping cables and everything else. You may want to stay away from there because it's going to get crazy. Make sure you turn in your evaluations. Thank you again for coming. I wish you all the best. If we can help you with anything, please give us a holler. Thank you.